This is Willie Kemp. This is Disorders of White Blood Cells, Part 5. And then there's one more after this. There on my webpage today with Dr. Hughes where we have questions. And also then there are my Twitter names. I haven't posted in a while, but I'm going to get back into doing that. And then like I said, I'm a forensic pathologist, but I have a really strong interest in general and systemic pathology. That's not trauma. And I really enjoy teaching the medical students. So please stop, read these, make sure you agree. If you don't agree, don't view any more of the lecture. And then one more disclaimer, same thing. And then also, like I said, if you want to understand my teaching methods and that, then I create an introductory one so you can kind of see it through there. So, and then there are my references again. Like I said, a lot of really good books. I think the Clinician's Guide to Laboratory Medicine is excellent. They guide you through test choice and how to form a differential that way. Dr. Stearns guides you through differential diagnosis through key clinical points. Make it stick. Great idea if you're ever going to be a teacher, but also if you just want to learn. Bakerman's is very tough to find in my experience, but it has good for lab tests. It's amazing because it was a required book for us when we were in medical school. And of course, Robbins. And then thank you to the University of North Dakota again, the Department of Medical Laboratory Science. Great collection of hematopathology that they allowed me to photograph. So question, so pause, look at it, see if you can answer it, and then we'll go through it at the end, and this helps guide you as you're going through the lecture and key in on certain things. So the last lecture, on lecture 5, I did pause on large granular lymphocytic lymphoma because I had a kind of an error in there, so I wanted to correct it. So the T cell variant, you have lymphocytosis, so you have increased number of lymphocytes, but not lymphadenopathy. So that's correct. And they'll have splenomegaly, but not hepatomegaly. So before that, I had hepatosplenomegaly, which technically is true. They don't have enlargement of both the liver and spleen, but they do have enlargement of the spleen, just not the liver. So sorry for that error, but I wanted to fix that. And then it says that basically the NK is very subtle. They oftentimes don't have any of those features. So I would think it'd be a tough diagnosis to make. So I just wanted to make that correction. Sorry about that. Okay, so we'll talk about Hodgkin's lymphoma. So Hodgkin's versus non-Hodgkin's, and everything else we've been talking about has been non-Hodgkin's. Hodgkin's lymphoma tends to involve one lymph node or multiple lymph nodes in a contiguous chain, whereas non-Hodgkin's tends to be more diffuse. So if they're presenting with femoral and axillary and cervical lymphadenopathy, it's probably not Hodgkin's because they're not contiguous chains. And then Hodgkin's lymphoma rarely has extranodal involvement, although when they're staging Hodgkin's lymphoma, when I was a resident and they did that, they would oftentimes take out the spleen. I think there can be some splenic involvement in Hodgkin's, but usually there's not extranodal involvement. Whereas non-Hodgkin's quite frequently has extranodal involvement, and we talk about something like Burkitt's. Look, Burkitt's oftentimes in kids in the United States presents in the GI tract, and so you can see extranodal involvement. So Hodgkin's has several types. I have a chart at the end where it kind of ties them all together and goes through and summarizes it, but I'm just going through one by one. So nodular sclerosis is actually the most common. Most of them are found more commonly in males than females, but this one in males equals females. And usually found in adolescents and young adults. Location is often lower cervical, supraclavicular, or mediastinal. So usually I think of mediastinum, I think of Hodgkin's. Although remember, the thymic T cell ALL is what also presents in adolescent males, which would be like Hodgkin's, and that one can have the thymic mass. The characteristic feature of Reed-Sternberg cells. So the classic Reed-Sternberg cell is actually in mixed cellular Hodgkin's. In nodular sclerosis, you oftentimes see what are called lacunar cells. The nuclei can be kind of multi-lobed, they got multinucleoli, and then there's a clearing around the cell, i.e. the lacuna. And then the pathologic feature that you also see comes from the name, nodular sclerosis. So sclerosis is basically fibrosis, and nodular means it gets divided into nodules, so you see fibrous bands throughout the mass. So this is nodular sclerosis, Hodgkin's disease. To the top left, you can see the light pink areas are the fibrous bands, and then it's dividing the neoplasm into nodules. And then the bottom right, this is the lacunar cell, so kind of a multi-lobated large cell. You don't really see nucleoli. That might sometimes be fixation that. And then you see the clearing around them, which is the lacunar cell. So mixed cellularity is a second type. And the chart ties, because there's other ones associated with, some are associated with EBV, some are not. The immunophenotype varies, mostly just with lymphocyte predominant. And then I have a chart at the end that summarizes all that. So I figured I would just go through some of the basic stuff here and tie them all together with that. So this one is actually older patients in nodular sclerosis. This one has the classic Reed-Sternberg cell. So what you have is you have a nucleus that has two lobes, and each of them have a large, very prominent nucleolus that basically looks like a viral inclusion. So it kind of looks a little bit like CMV. And then what that does is they say that the inclusion will actually be the size of a lymphocyte. And then the mixed cellularity is the background. And so you see macrophages, plasma cells, eosinophils, lymphocytes. And so actually the neoplastic cell, being the Reed-Sternberg cell, is not by far the most common cell in this. A lot of the other ones are just this reactive mixture of other types of inflammatory cells that you see. So this is a mixed cellularity, and sorry, in putting the things together, I kind of cut off a lot of the eosinophils, but you can still see there. You can see the eosinophils in the top left, multiple little red cells. So this is I think that's kind of the best thing, because lymphocytes, plasma cells from this power, macrophages might be a little trickier, but the eosinophils are distinct. And so this is a mixed cellularity, and then the bottom right is the classic Reed-Sternberg cell. So you can see right in the center, or just a little bit off center to the left and lower, is a binucleated cell, and each of the nuclei have a large nucleolus that is about the size of a lymphocyte. So that's a classic Reed-Sternberg cell, which are usually seen more in mixed cellularity. Lymphocyte predominant is a rare version, and it's different than the other ones. You'll see with the immunophenotype when I have the table at the end, ties them all together. This one is seen in young males. It's cervical, mediastinal, or axillary, so same thing as nodular sclerosis. And then the Reed-Sternberg cells are what they call LNH, or lymphohistiocytic, or they call them popcorn cells. They're kind of multi-lobated. And just so you know, these images I get, these came from other people's diagnosis of Hodgkin's disease. So I've had access to a variety of teaching sets and other things like that. So it's not my diagnosis. And these actually may have come from the California Tumor Tissue Registry, because lymphocyte predominant is fairly rare at 5%, and a lot of their cases for their unknowns were more rare ones. So you can see multiple multi-lobated, with multiple nucleoli cells throughout. Those are the popcorn cells, and this was lymphocyte predominant. So here's the chart that I've been saying. So I talked about nodular sclerosis. I talked about mixed cellularity. I did not talk about lymphocyte rich and lymphocyte depleted. These are two pretty rare, pretty uncommon versions of the classic Hodgkin's lymphoma. And then lymphocyte predominant, because of what you'll see with the immunophenotype, is not a classic Hodgkin lymphoma. The immunophenotype for classic Hodgkin's, they're CD15 and CD30 positive, all of them, and they're CD45 negative, whereas lymphocyte predominant is CD15 and CD30 negative and CD20 positive. So I think that is actually a fair immunophenotype to actually ask a question on, because it's different than the other ones we've been talking about. And there's some change there. So like I said, most of them are found more commonly in men rather than women, except for nodular sclerosis, which is the most common type and has about male, female equally. Then I listed the pathology there. The classic Reed-Sternberg cell, the binucleated, large nucleoli, viral-like inclusion size of lymphocyte, is usually what you see in mixed cellularity. And then lymphocyte depleted, you just see a ton, and then less of the background cells. And then nodular sclerosis, you see the lacunar cells, and then that nodular sclerosis is the fibrous band dividing into nodules, and then lymphocyte predominant is the LNH, or the popcorn cells. And then EBV, mixed cellularity, is very common, about 70%. Lymphocyte rich is at about 50%. Lymphocyte depleted, the best I could get was most. And then nodular sclerosis and lymphocyte predominant are actually negative, or at least most nodular sclerosis is negative for EBV, which I think is another important association to know. So basically the way it works is it says it produces proteins that inhibit T cell function, and then the genetics behind it, you can have an amplification of the chromosome 9 region that contains PDL1 and PDL2 that inhibit T cell function. And then remember, the way this would work is, remember, the T cells act to destroy a variety of cells, including neoplastic cells. The immune system acts against neoplastic cells. And so if you inhibit that T cell function, you can allow the neoplasm to grow unimpeded by the body's immune system reacting against it. Okay, so here are my two kitty cats. Loki's on the left, Mochi's on the right. They're enjoying, they like sitting at the top of the stairs saying, look down. And then the picture in the back was actually interesting. My wife took that. She's a better photographer than me. And she actually took that to a photographer who actually refused to print it because it wasn't quite up to their standards. I'm like, what? So she did find someone who actually did print it, and I think it's a pretty neat little picture. So, okay, so forms of myeloid neoplasms. I mentioned this on the first lecture, but again, acute myeloid leukemia, myeloproliferative disorders, and myelodysplastic syndromes. We'll talk about these. So acute myeloid leukemia, or AML, these occur, most of them around the age of 50 years. So it's a disease of adults. The clinical presentation, just remember, when you have a leukemia that's growing, you produce tons of the neoplastic cells, and that will wipe out the normal bone marrow potentially. And so they could develop anemia, they could develop infections because of no granulocytes, they could develop bleeding disorders because of no platelets. And it's acute, so they usually present relatively quickly. So it says weeks to months after the disease process starts. It can rarely present as a mass, what's called a granulocytic sarcoma, and it can present with involvement in the skin or leukemia cutis. There are numerous forms of AML. When I was in medical school, we learned AML M0 to M7 based upon what the precursor is, with the M0, M1 being very undifferentiated, up to 6 and 7, which were the erythroid and platelet derived. The ones around 4, 5, and 6 are monocytic, and that's still used if they can't be better identified. But the classification is always changing, but it's good. Well, relatively always changing, because hematopath is very much dependent upon, it seems like, or very much utilizes genetics, and that's always a growing field. Unlike forensics, that doesn't use genetics as much, for sure. And so it's always changing, and so that's why we see change in the classification. I think I always use this thing that I think the classification scheme for lymphoma changed like 3 times in the course of my 5-year residency, whereas the classification for gunshot wounds didn't change once. So anyway, sorry. But a lot of them are based upon, the AML 0 to M7 was based upon kind of morphology, but also different types of stainings. A lot of them now are based upon genetics, and these translocations are very important. A lot of these translocations I'm going to go through are the same ones I learned, so they're very important for you to know. AML has myeloblasts, so greater than 20% of the bone marrow will be blasts, and that depends on what form it is, but they can be myeloblasts, monoblasts, erythroblasts, megakaryoblast. And there's a range for the immunophenotype. I just put some of the positivity there. It's going to depend upon which one it is and stuff like that. And to me, I think that's beyond what you would need to know, I hope. So this was actually a leukemia cutis. You can see the person to the top left had a whole bunch of little red spots. It wasn't Tardieu spots associated with lividity. What we see in postmortem changed quite a bit. So I thought they were going to be petechiae, and I sampled and I looked at that, and it was neoplasm. So I took that obviously to one of the other pathologists who sees the stuff in it. So it was leukemia. So acute myeloid leukemia, there's different categories they use. AML with recurrent chromosomal translocations. So we'll talk about 8, 21, 15, 17. AML with multilineage dysplasia. AML that's therapy related, and then AML which is not otherwise classified. So this is where it reverts to the French, American, British, which is the one I learned in medical school, the AML M0 to M7. So once again, these AMLs, these are not my diagnosis. These are based upon pathologists who know hempath. And I would not expect you, I would hope the majority of these you would not be expected to be able to identify. Some of them have some features that you can see, like erythroid looks like red blood cells, like nuclear red blood cells, abnormal. The megakaryocyte look like giant platelets. And then the AML-M3, the acute promyelocytic leukemia, the one associated with 15-17, has hour rods. So something like that I would expect you to know. But as far as like telling, to me, like the equivalent of an AML, M0, M1, M4, M5 are much more tricky. And I think that's beyond what I would hope they would ask you as a medical student. So AML-M2, this is the old one. It's most commonly associated with the translocation of 821, and you can see single hour rods per cell. And so the arrow shows some of the hour rods that are in the cells there. And then M3 is the what also has been called acute promyelocytic leukemia. This one stands out. It has 1517, which is PML RARA, retinoic acid receptor. This one can actually be matured, and the person can actually do fairly well from it. And it's also the one that's commonly associated with DIC. So this is actually a medical emergency, this diagnosis, because of that association with DIC. And this is when we could actually be called in as residents to help make that diagnosis. So they usually have multiple hour rods per cell. The one in there shows one, but I'll show you one later where there's multiple. And then once you start getting to M4, M5, M6, or M4, M5, it seems like that goes more to the monocytic lineage, and then M6 and M7. So M6 is the erythroid, and you can see right there in the center is one leukemic cell, and it kind of looks like an abnormal nucleated red blood cell. So that might be one they could show you. And then to the right is megakaryocytic, and you can see the giant platelet there. So I mentioned the acute promyelocytic leukemia, the old one AML-M7. This is the one associated with 1517. Like I said, you see multiple hour rods, and one important point is it's associated with a risk for DIC. So I was always told in residency it's kind of a medical emergency, the diagnosis of it, to get them treatment so that they do not go into DIC. So the top left, this is a bone marrow smear, and the cells at the end of the arrow you can see have multiple hour rods. So the hour rods are like a little eosinophilic, elongated rod in the cytoplasm. To the right of it is a microthrombus, and so this is what you would see in the kidney, in the glomerulus. You can see there filling that vessel. So you can see that that's what would happen in somebody with DIC. So when I talked about the categorization of them and the recurrent chromosomal translocations, then I listed them. So like I said, 821, it's the RUNXT1 and ETO. Inversion 16 is sometimes associated with eosinophils. 1517 is the PML retinoic acid receptor, the one that can be matured. And then there's one associated with 11q23. But I think, like I said, the biggest ones to me are the 821, the inversion of 16, and the 1517. Those were well known at our time. I think also 11q23 is a fairly important one. So, okay, so here's the question. So go through, pause, look at it, answer it, and then we'll get the answer. Okay, so if it's CD15, CD30 positive, so it's not lymphocyte predominant. There's a heterogeneous inflammatory infiltrate, lymphocytes, plasma cell, macrophages, eosinophils, which goes along with mixed cellularity. And then here is the answer they wrote at the time I wrote the question. So once again, what I would suggest doing is pausing, thinking back, going, okay, what are 5 important points that were said during the lecture? And like I said, I hope I made 5 important points. And this technique is very good for helping cement that information in your mind and helping retain it. And that's why, like I said, I don't give a summary, because this makes you come up with a summary on your own instead of just defaulting to what I show you. So when I moved to Grand Forks from Missoula, Montana, I learned about the concept of a sundog. So a sundog is basically a rainbow around the sun, and it's caused essentially by ice crystals in the air. So you usually see it when the temperature is 20 or 30 below. So I had never seen one in Missoula or Libby, Montana, where I grew up, but I did see them in Grand Forks quite commonly. And when I got back to Billings, which can also sometimes get minus 20, minus 25, I actually did see a few. So this is one of them. I've never actually seen one where it went all the way around the sun, but I have seen ones like this. So I think it's a really pretty winter scene, just as long as you realize it's about 20, 25 below out there. So I hope this has helped you in your understanding of neoplastic disorders of white blood cells, and thank you.